80 to 95%. Just let that number sink in for a second. That is the staggeringly high first-year relapse rate following treatment for things like nicotine, heroin, and alcohol use. It's a massive figure, and frankly, it demands our attention right out of the gate.
It really forces us to take a step back and ask a difficult but absolutely essential question. With relapse rates sitting that high, are we actually matching the right treatments to the right people? Or is there, a fundamental disconnect between how we conceptualize addiction and the treatments we ultimately prescribe? That is the core mystery we're going to try to solve today.
Welcome to The Explainer, everyone. If you, or maybe anyone you know, has ever been touched by addiction, you already know just how incredibly complex it is. Today, we're going to unpack the science, the psychology, and the real-world realities behind how we match interventions to addictive behaviors. Here is our quick roadmap. First, we'll look at the addiction puzzle. Second, matching models to interventions. Third, we'll dive into some reflections on mutual help. Fourth, the harm reduction alternative. And finally, we'll look at the reality of treatment. We've got a lot of fascinating ground to cover, so let's get into it.
Part 1. The addiction puzzle, how we define the problem.
Okay, so before we can even talk about the cure, we really have to talk about how we're defining the root cause, because that definition completely dictates the solution we choose to deploy. Take the brain disease model, for example. This perspective points straight to neurocognitive impairments. It views addiction as an automatic, habitual, drug-seeking behavior that's driven by biology. On the flip side, we have the behavioral or psychosocial model, which argues that addictive behaviors are actually driven by learning history, environmental context, and reinforcement over time. We aren't taking sides here. These are just two very distinct clinical lenses for the exact same challenge, and they lead us down totally different treatment paths.
Moving right along to Part 2. Matching models to interventions, the rules to gameplay. So, once you pick a lens, you basically have to follow the rules of that specific game. Let's see how this builds our clinical strategies. If we're looking at a patient's addiction through the behavioral model, the perfectly matched intervention is cognitive behavioral therapy, or CBT, right? It teaches patients to relearn behaviors. But what if the addiction is rooted in emotional dysregulation? Well, then we match it with a transdiagnostic approach like dialectical behavioral therapy, or DBT, which works across disorders to help regulate emotions. And for co-occurring disorders, say addiction combined with a mental health condition, we're matching them with integrated dual-focus care.
Now, let's zoom in on how a specific intervention actually breaks the cycle of addiction on a granular level, using mindfulness-based interventions as our example. It all starts when an internal or external cue hits, triggering a craving. And that craving is the critical moment. Mindfulness steps in right there, allowing the person to just observe that craving without immediately acting on it. Ultimately, they develop an adaptive coping mechanism without needing the substance. It's a beautifully structured match for interrupting that reward-based learning loop.
Part 3. Reflections on mutual help, community over clinic. But look, clinical models absolutely have their limitations. What happens when the patient leaves the therapist's office? This is where peer support networks fill an incredibly vital gap in recovery that clinics, frankly, sometimes just can't. Dual recovery mutual support involves groups where individuals use their shared personal experiences to manage both their addiction and their co-occurring mental disorders, together. For folks navigating complex, dual diagnoses, leaning on this shared lived experience is absolutely paramount.
And it brilliantly illustrates the profound psychological and social benefits of these groups. You get fellowship building, actually meeting others who truly get what you're going through. You experience emotional acceptance and empowerment. You gain clear direction for your recovery, drawn from a collective lived experience. Plus, you build a deep sense of camaraderie and community. This isn't just a nice little bonus. For many people, this community connection is literally the primary engine of their recovery.
And we aren't just guessing here. The empirical evidence backing this up is incredibly strong. 12-step facilitation has actually demonstrated greater efficacy than alternative active treatments for alcohol use disorder, particularly when it comes to supporting continuous abstinence. Facilitating mutual support isn't just some afterthought, it is a highly effective evidence-based intervention in its own right.
Part 4. The harm reduction alternative, prioritizing safety.
Now, that being said, complete abstinence isn't the only path. We have to face a pretty harsh statistical reality. Only about 1 in 10 people with a substance use disorder actually end up receiving treatment. For many, traditional abstinence-only models are just alienating. Harm reduction, on the other hand, prioritizes immediate health and safety over methods that focus solely on achieving total abstinence.
If someone just isn't ready or able to commit to complete sobriety, harm reduction is the perfectly matched intervention to ensure they're still getting life-saving support and care.
Finally, Part 5, the reality of treatment. Why we actually choose care.
So let's shift away from clinical idealism for a second and get into real-world pragmatism. Why are interventions actually chosen? Well, look at the sheer scale of the data here. With 17.6 million SUD-related ambulatory medical visits between 2009 and 2011, we see that intervention matching isn't always about finding the perfect clinical theory. It's often simply about availability. People go where care is accessible, and very often that is in primary and acute care settings, not specialized addiction clinics.
And when patients were actually asked about their willingness to enter treatment, only 24.6% were willing to go to specialty care. But for primary care, that willingness jumps up to 37%. Why? Because people perceive a massive lack of stigma in primary care environments compared to specialty clinics. Access and stigma are the real, everyday driving forces behind how interventions are matched and utilized in the real world.
We also absolutely have to confront the reality of equity in our treatment models. Many evidence-based interventions have not been evaluated among marginalized groups. And honestly, this is a massive blind spot in the field. We just cannot assume that our clinically matched models work universally across all demographics if they simply haven't been tested there.
Take the REMAS study as a prime example of this disparity. The study successfully reduced sexual risk behaviors among men who use substances, but, and this is crucial, subsequent analyses revealed that the outcomes for Black men were not as positive as the outcomes for white men. This urgently highlights why our case conceptualizations have to include social determinants of health, cultural context, and historical inequities. Because at the end of the day, a treatment isn't truly matched if it doesn't fit the patient's lived reality.
So what should you take away from all this? It's that addictive behaviors have just as much to do with environmental contexts and social determinants as they do with biological brain mechanisms. Finding the truly perfect matched intervention means marrying those biological insights with the everyday realities of habit, access, culture, and community.
Which leaves us with this final, kind of provocative thought to chew on. If addiction is driven by our environments, our access to care, and our communities just as much as our biology, should our greatest interventions actually be happening completely outside the clinic? I'll leave you to ponder that one. Thank you so much for joining me for this explainer, and keep questioning the science.